kick off, I'll hand over to her.
All right, I'm starting. First time I did this was an hour, the second time was half an hour, so this is my practice of getting it down to 8 minutes. I'm Brooke, I'm from the Research and Evaluation Office, and we supported an evaluation for the Rauemi Atawhai program that was actually coordinated by Suneva Sinclair, who is not here this afternoon, but does have a beautiful poster out in the foyer. So for those of you who don't know, the Rauemi Atawhai program is based on the Ministry of Health Rauemi Atawhai framework. It's a framework for building health literacy of organisations, and the program that we delivered here at Counties kind of had two main objectives. Those were to support staff to be able to develop and identify health literate, culturally competent resources, and the second was to help staff within their services to build systems and processes for the development of those resources. So when we say resources, we mean the things like consumer documents or brochures that are provided to patients or consumers when they visit healthcare professionals or online. This was the first time last year that it was offered at Counties Manukau Health. So Suneva and her team were really interested in some evaluation, which was why they approached us. And they really wanted to get an understanding of what learning were people gaining from the program, what system or service level changes were achieved as a result of the program participation, and moving forward, what opportunities kind of existed to further improve the organisational health literacy and what the barriers to those might be, which you'll see there were a few. To help us respond to these evaluation questions, we had a number of data collection tools as part of our evaluation design. Those involved some document review based on a pre-designed tool. So we looked at consumer documents and reviewed them for before and after based on their actionability and understandability for consumers or patient groups who would receive them. We also did some interviews with the program participants to get a feeling for their understandings of health literacy and how those systems and processes currently work within their service. They also completed before the program a health literacy survey, which is a Ministry of Health existing survey, which they then completed after as well. We had a follow-up interview with them, some interviews with senior leaders afterwards, as well as a focus group with the team who actually coordinated the training. So in total, 9 of the 15 participants who did the program participated in this evaluation process. In terms of findings, the team were really interested in understanding what people actually gained from the program in terms of their learning, and we did find that the health literacy results didn't reach statistical significance, and in fact, for many reasons, we've decided we're never using that tool again. The qualitative insights were really useful for us in terms of asking people about their learning, both before and after the program, and their understandings of health literacy. These 3 things summarise some of the key themes that are further explored in the report, but briefly for you today, I would say that they gained a real understanding around perspective in terms of the importance of having consumer or community feedback, perspectives and insights during the development phase when they are developing resources and building health literacy. They gained from it a clear structure or process for how they should go about that, and that was something that you'll see in a moment was quite absent from the services who participated, and it gave them a real clear direction and starting point for how they should develop consumer resources in the future. And finally, interaction, which related to the fact that people really gained an understanding of, in fact, they are the resource. It's not the piece of paper that they're providing. The piece of paper is an aid that's part of a broader interaction where the health professional is actually doing the job of building health literacy, and this resource that they take away is a reminder for them to reflect on later, but they should really be doing the job of all the health literacy building in their interaction with them. So the resources really that they take home was just one part of a broader tool and a communication package that they should be using. Okay, system and service changes. This is one that I felt sceptical about before the program, and one that I still feel sceptical about, because as you'll see from up here, there were really limited, when we interviewed people before, very limited processes for the development of consumer resources within services. 50% of them reported that they didn't even have one. 63% reported there was also no system for selecting, accessing or storing resources. So people were in a position where they were working within their wards or services and literally finding things on shelves and drawers in their own folders. There was no really systematic way for how they were accessed or stored, and nor was there for the consumer resource development, which tended to be quite ad hoc and on a needs basis. As people came across something that they felt they needed, they would fill a gap and design something. So the picture of our kind of current state of the development of consumer resources wasn't really a pretty one, but keeping in mind the limitations of this in terms of this is feedback from 9 people, we don't know how much this is happening across our organisation, but I think this points to a need for us to understand that a bit better. These were some of the problems where there were existing systems in place with them. So most of them lacked formalisation and sustainability. They depended to rely on somebody within their service who was really passionate about health literacy and consumer resources, and therefore put all their energy and time into doing that on behalf of their service. If those people were to leave, there isn't necessarily somebody in another position who would take that over, or somebody familiar. The processes and systems aren't necessarily known by all the staff, they're not in policy, etc. So there are some key problems around the sustainability and formalisation of the systems that were actually there. What we discovered was that there were actually a lot of barriers to people in terms of addressing health literacy within their services, and a lot of that came down to really our organisational approach. I did mention that the people who were doing the program were quite passionate about health literacy themselves, and that meant that they could take some action within their services. Because of the type of people on the program, they were often limited in their scope of influence with the things that they wanted to change, and that's been great program learning for the people who deliver the program, because it's made them think really carefully about who are the type of participants they have, what their scope of influence is, and who else they need to be targeting for this kind of material to ensure that they are able to make the system and process changes that they are aiming to. So one of the things that came up from staff time and time again, which you'll be familiar with, was around funding and resourcing of health literacy initiatives. This was actually quite a tension, because in fact we identified that health literacy is an organisational priority, but people weren't able to access any human or financial resources to support their local initiatives and their wards or systems. We are slowly beginning to increase our organisational accountability for health literacy. Thank you to Jenny Parr, who has joined us and is taking on some responsibility for this across our organisation. But awareness and prioritisation of health literacy has really differed across wards as well, which makes prioritising it really difficult for some services and wards. And we've already talked about lack of consistency in processes and systems. Thanks, Alan. I'm going to skip to my conclusion. We had a number of recommendations coming out of this, some related to the Rauemi Atawhai program itself, and some to our organisation. In terms of the program, I've already mentioned they really wanted to look at the scope, influence of program participants, and making sure that people applied and practiced the resource as they went to increase their program output. So actually the number of consumer documents that are churning out of the program, which are improved. At our organisational level, there's a lot of commitment still required here, but there were some key ones which Suneva would be better to speak to in terms of progress with those, because she is still pioneering on her health literacy pathway. Thanks. 8 minutes 50.